Let's talk about management of dementia. First, we'll discuss activities of daily living, referred to as ADLs, challenging behaviors, contractures, balance and strength issues, sensory deprivation, fall prevention, and activities. I'm an occupational therapist, and most of my terminology comes from the Occupational Therapy Practice Framework. The most current one that I've read was 2002, though I've heard that the 2008 supports this particular vocabulary. ADLs are activities of daily living and include activities, work, and leisure. These are practice areas for occupational therapists. Nurses have adopted World Health Organization terminology, and the Occupational Therapy Practice Framework has also adopted World Health Organization terminology. So this is a list of vocabulary that should be familiar with most healthcare professionals that work with clients in a rehabilitative or medical type setting. Usually, occupational therapists will write that the client will show improved independence or competence in ADLs globally. But with dementia, remember, when your clients are making slow progress towards goals, we want to break goals into smaller components so that we may measure the minutiae of gains. This is what's helpful about the terminology, for there are 3 areas of ADLs that you can document. IADLs are instrumental activities of daily living. Most require executive management performance functions, like balancing your checkbook, making medical choices, making appointments, domestic chores such as cleaning, cooking, laundry, light home management tasks. Basic activities of daily living include washing, dressing, eating, and sleeping. Personal ADLs are more meticulous. They may require tools involving chores or self-care skills that require we're going to edit this out, but brushing your teeth, shaving, taking your vitamins, taking your medicines, emptying your colostomy bag, toileting, those are all exercising, those are all personal ADLs. So you could work on one of those performance areas. One performance area that has me greatly concerned is driving. Some people drive that make me nervous. Know that you can refer your client out to a therapeutic driving program to assess these skills. Don't just work on the car transfer with your client and then assume because they can get in and out of a car that driving's going to be okay. There's a lot of cognizance and processing and short-term working memory required to drive safely in our community. And just because a client can pass the DMV test for driving does not necessarily mean that they will be safe driving at night, long distances, such as going on the highway, new locations as opposed to familiar locations. A therapeutic driving instructor is well equipped in assessing those skills. They may give cognitive tests such as the short blessed, the sequence trail making A or B. Many times we see a virtual road test before an actual road test, and recommendations are made. It is usually an out-of-pocket expense, though Medicare has started to cover the assessment portion before going on the road, the time with the therapists, so that does cut costs. If Medicare is covering, then it's probably only going to be $100 out of pocket. If Medicare is not covering, about $300 out of pocket tops. And my sales tactic is, hey, it's a lot less expensive than learning by mistake that you shouldn't have been driving. There are different ways to assess people who are having performance difficulties in their ADLs. You could provide physical assistance. When the client's having a hard time doing something, you just help them do it or do it for them. You could also provide verbal cues as an assistance through communication. gestural cues, written cues, and visual cues. We'll go over them more thoroughly. Depending on your profession, or perhaps you're not a skilled caregiver, perhaps you're a family caregiver or a lay caregiver, you could use one or maybe several of these skilled cueing techniques to help your client perform. And the way you use them proportionally, is going to be determined by how much time you have with the client. Therapists have lots of time to work with the clients on a specific skill. So let's say I might have an hour to work with my client on getting washed and dressed. I would be more apt to use verbal, gestural, written, and visual cues to help the client perform. But what if I'm a nurse assistant and I have only 15 minutes to have my client get washed and dressed during my time? Well, I would be more apt to give my client more assistance rather than the skilled cues to help them perform, because it would take more time to get that particular ADL done. A note on documentation for the clinician: it would be a good shortcut to think about how would your client perform this ADL task if you did not give them any skilled cues to help them perform. If your client has a GDS score of approximately 1, the client may require no skilled cues to help perform their ADLs. At a level 2, in the absence of skilled cues, the client may only require setup to perform the ADLs. At a 3, the client may need supervision, distant or close supervision, with no skilled cues. At a GDS of 4, we're talking early stage dementia, without skilled cues, the client may need minimum physical assistance, and so on and so forth. The reason why I wrote that this way is when you perform an evaluation as a skilled clinician, you must record how the client would perform in the absence of skilled cues, because skilled cues are not the client's level of performance. Skilled cues are a therapeutic service that you provide. It is actually a treatment. So when you fill out the evaluation, you should be a very harsh critic on the client's performance so that third-party peers will understand the benefit of your skilled service, which you will reflect in your documentation. When you document the evaluation, use the physical assistance value. The skilled cueing strategies are for the treatment, and then use lay terminology for the care plans. I'll give you an example. Perhaps you're working with a client that when they go to sit down on the commode, they sit about 45 degrees away from the commode. Now, a nurse assistant is not using skilled cues at this time. They're more apt to physically move the client to sit on the commode. So on the evaluation, you would probably write minimum physical or moderate physical assistance for toilet transfers. On your treatment note, this is where you write down that the client was able to sit down on the toilet with verbal and gestural cues in an elevated toilet seat with close supervision. And then you can make a goal that the client will demonstrate this competency more than once, because our clients can be very variable in their performance. So client will demonstrate the ability to transfer with close supervision, an adapted device, and skilled cues 2 out of 3 days. You get the return demo of the skill, and then you can make a new goal. Client will demonstrate the ability to transfer with close supervision, an adapted device, and skilled cues 3 out of 4 days with various caregivers. It would be prudent to write your goals like that so that third-party payers can see the immediate benefit of your exchange and the need to educate caregivers with the patient around to demonstrate the techniques, that the client may not be the only one varying in function, but he may vary in function dependent upon which caregiver is working with him, and they need to be trained on the skill. On the lay terminology for the care plan, what I'm saying is I'm not going to say that the client's supervision, adapted device, and skilled cues for transfers. In fact, I would write a script. Stand next to the client during transfers and point to the left side of the toilet, telling the client, move your bottom more to the left before you sit. Stand by in case the client loses balance. So hopefully that will help you. Here are some of the skilled cues that I may provide to help enhance my client's independence. Verbal cues are when I break down steps into smaller components. If English is a second language, oftentimes clients with mid-stage dementia revert. Often clients, once they enter mid-stage dementia, revert to their primary language. And this is a very difficult time as a skilled clinician if you do not know their primary language. Google Translate is very helpful for me in that effect that I could translate a single word from English to their language. I never translate an entire phrase to their language on Google Translate because computers just miss that art of communication. And plus the client's receptive aphasia may be so exacerbated at this time, even if we did speak to them in their primary language, they may not be able to process it. So I have 5 functional words that I use to help communicate: eat, drink, copy me, sit, and toilet. Those are very functional. You may find other words that are helpful to you. One word I don't usually ask is pain. I'm more apt to use the Wong-Baker facial scale for pain because clients with dementia are very poor at reporting their pain levels. Oftentimes they may say 10 when they're smiling. Gestural cues are another form of communication techniques to help Gestural cues are another form of skilled cues to help your client perform ADLs. 90% of what you say is gestural, and since our clients are very strong in interpreting visual information, the gestural cues that we provide may be key as an element in communicating with our client. I always watch my facial expressions when I'm working with the client. If you're an expressive sort of person and you're having a bad day, this is a bad session with your client. If you're having a great day, or you could at least fake it, smile, look calm. Act like you're not in a hurry. Try not to look at your watch when you're talking to your clients. These gestures guide your interactions. Gestures change meaning across cultures, and if you're a hand talker and you do a lot of symbolic communication, like American Sign Language, this means I love you, you could be making a mistake while using that type of communication with your client that's hard of hearing. Perhaps that client that's hard of hearing is Italian, and you just gave him the evil eye and cursed his family. Not a very good session. Maybe you learned that 2 thumbs up means good job. But what if your client's an Air Force veteran? This means eject. Do you want to tell your Air Force veteran that he has good wheelchair mobility? One day I was washing my hands at the sink like this, and one of my clients said, "What are you scheming?" Without the sink, I looked like I was scheming. So I just turned to the client and said, "Mwahaha, wouldn't you like to know?" A handy book to buy would be International Business Etiquette. Most of those books tell you do's and don'ts for gestures and communication with other cultures. In New Hampshire, we have a very large white Caucasian population, and during the summers for blueberry harvesting, and even from Bosnia, we have a Bosnian, Puerto Rican, Mexican, white Hispanic, Somalian, we have a lot of people from India that come here to get jobs in the healthcare positions. Now, we really have no excuse to say that New Hampshire is white and that we don't need to learn about other cultures. The more you learn about other cultures, the better we interrelate. The less mistakes we make, the better it is for business and healthcare, because it'll help us understand why our client wants to work with us or not work with us. Let's say you work with a Vietnamese family. I've made the mistake. I guess they don't like to have a lot of eye contact, and I worked with one of their children, and the family wants to be present during every therapy session, and they want the child to dictate. They guide their own play. They're very Montessori about it. Let me see. A Cantonese Chinese family that I had worked with, it took them an entire month to feel comfortable sharing with me their concerns about fall risks in the home, health concerns, difficulties with the exercises. They're very high context. You really need to know a family for a long time for them to share information with you. The Indian culture is more candid. They'll tell you exactly what they think, maybe more open, but their family's more closely knit than maybe other families. My ex-husband is Greek, and therein is another culture that I would want to consider. And now we would understand why people have different point of views, different routines, different responses to life tragedies, off-time events. I took a cultural competency class in college begrudgingly and surprisingly learned a lot. Hopefully these types of courses go from West Coast over to East Coast because I think we could use those courses. But one of the simplest and easy to remedy mistakes that caregivers make is eye contact. Make sure that you give your client at least 2 to 6 seconds of eye contact. Otherwise, your client will think that you don't like them or that you really like them, depending if they're the same or opposite gender. And again, have a nice, calm, and pleasant approach. I had a woman come up to me after one of my classes, and she said, I don't know what it is. I don't understand, but for some reason, my client likes everybody but me, and I don't know what it could be. I think the gestures really have been painting the sessions. Even though she says really nice things, she's got her hands up, she's got this kind of very aggressive, confrontational, Guilford Godfrey type of posture, and not really very good eye contact, and she looks kind of maybe disgusted or enraged. So we would really want to work on that, unless she wants to use it to her advantage. She could be this person that the client says no to, and then send another caregiver in playing good cop, bad cop, which we'll talk about later. Brinton cues are effective as long as your client can comprehend reading. Many clients read, but they don't understand what they read, or they can't recite back what they read. Language, you could write more descriptive cues in the earlier stage, like some simple steps on how to safely use a walker. But really, once the client has 4 simple steps on how to use a walker, they're not reading those directions. Oftentimes, if the client's having a hard time reading, I decrease the amount of words that they have to read, and I will revert to simple noun-verb combinations for those later stages of dementia. So rather than the steps on how to use a walker, I might just write their name on the tag of the walker or have something that says, "Take me with you." Visual cues are extremely effective for clients that have dementia. Oftentimes you'll find me hanging up signs, be they symbolic or pictorial, like traffic signs or Polaroids or Meyer-Johnson type pictures. I alter lighting to help enhance or decrease an environment. Like turn on the light to the bathroom so that I could tell them where we need to go, or turn the light off in their bedroom so they know this is time to leave. Another thing I do is I provide a visual contrast using colors that pop or colors that decrease the client's willingness to attend it. Let me show you some colors that I have in my office here. All right. Lanny Butler loves this color, neon green. He says that green is the most visually salient color with diminishing vision. I've had neon green shoelaces on my sneakers, and I get several compliments from my clients with dementia on how nice my shoes look. And of course, those clients all come from the same lady, but it counts. I like this light blue color. It contrasts with every other color around it. So if I wanted to maybe serve a client lunch, we could see that it would contrast with everything that's on it. The client would be more likely to eat their potatoes because rather than if they were having the potatoes on a white plate. And here you see several dementia colors. Any of those highlighter colors, use those to bring out small details in your client's environment. So something that you want them to grab or notice, like a daily list of their schedule or precautions or something that they need to do next in their day. White seems to make things disappear. So if I had a client who had Parkinson's disease and I were to tape some white paper underneath their door frame, they'd be less likely to stop and freeze in the doorway because they wouldn't see something that interrupted their motor pattern. And as I said about black can be seen as bugs, trenches, holes. So oftentimes I'm not using black. Although I have used black anti-skid tape, and I will, write words in black from the computer, and I have used black toilet seats. Those are the times that I've used black. Oftentimes I don't really wear black at work. I'm more likely, honestly, this is the color of most of our scrubs, but being very tall, my clients do notice me. I am 6'4", but many times they refer to me as him. That's okay. I'm confident in myself. A good lab to bring to your work would be one that you could practice using your skilled cueing strategies to enhance your client independence. The Cleveland Alzheimer's Association had suggested a light snack preparation activity. The case study is that your client, I've modified it. I have a case study that your client is in mid-stage dementia. So they're pretty settled in, they're not in transition. And your job is to use cues to get the client to make a light snack without providing physical assistance. Oftentimes, I'll get all of the ingredients to make a peanut butter and jelly sandwich. To act like someone who has mid-stage dementia, in your mind, I just have you play a game. Take the caregivers literally. If you hear more than 5 words, stop what you're doing, or take what's in front of you and hold it up to your mouth. You could alternate between those two things. And what else did I have for cues there? Oh, that you lost the name and function of all of the things that are in front of you. So peanut butter is no longer peanut butter. You just think of it as food. Jelly is food. Bread is food. Knife is food. Plate is food. So you have a receptive language issue. And then C, by using visual, gestural, written, not physical, avoid using physical cues. Verbal cues, you can use those. See how your client can perform. And then with the group that you're teaching how to use skill cues, we have some reflective questions to ask at the end of the activity. Go ahead and do it, and then you can come back to the video. What was hard for you? What communication styles were the most effective for you? What would you have done differently? What would you have done the same? I know some physical therapists might say, I would have just put that sandwich together. But hey, that would have been a great dynamic balance activity. Promote independence because it prevents excess disability. Excess disability is when you grossly underestimate what someone is capable of and do it for them. How do you know what someone's capable of unless you ask them to perform? Promoting independence helps assess capability. It reduces behaviors, as long as we reduce our subjective judgment on what the right way of doing something is. Seriously? White shoes after Labor Day? You know what? At least she put her shoes on. Promoting independence increases self-esteem according to American studies, especially clients who can feed themselves, walk from point A to point B, and toileting. Some people have their best ideas in the bathroom, but mostly it's for privacy, protecting privacy, and falls, because the number one place where people fall is to or from the bathroom. Everything else is subjective. It's all going to vary on cultures, on what goals clients want to work on. I know some women that were the family matriarch, took care of every single problem that their family has, and as soon as they fall and get debilitated, they can't do the rehab. Finally, their family's around, helping them out, being there for them, taking care of them, because in their minds, that mother had earned it. And that's something that I did not understand. Being a French woman married to a Greek man, once my mother-in-law she had slipped and fell in her yard one day, and she was gimping around all winter. And one day she asked me to hold her hand when she was walking down my icy driveway, and even though we had salted it, it just wasn't melting fast enough. She reached out, she wanted to hold my hand and put her arm around my shoulder while I walked her to the house, but I thought she was very capable, and I said, hey, walk to the house. And she says, what if I fall down? I said, I'll pick you up. I'll pick you up. She goes, oh, all right. And she walked into the house, and she was fine, and she resented me for it. But in my family, being French, we're very independent-minded, and we really want to try to protect as many skills as we have. But for her, in her culture, she certainly would have earned it. She'd done everything for everybody for years. People with dementia have superpowers. Not only are they having some deficits, but they really excel in some skills. One is being able to interpret art at a very adult level. They may be forgetful, but they never forget who told them that they can't drive anymore. They don't forget the words to their favorite songs. They don't forget how to play an instrument, like the piano. They don't forget their hair appointments. They don't forget that you're the lady who brings in the dog every week, or that you just had a baby. They're funny, intentionally or not. Some of them tell very good jokes. They're honest. They're physically strong. They're very physically strong. It's important to think about their strengths, because if you don't have the plasticity to improve their weaknesses, it would be imprudent to focus on their strengths. Anne Adams was a microbiologist who in her early 40s developed a new interest in painting. She'd never painted before, and when she picked up a brush, she found out she was very good at it. This painting is called Unraveling the Bolero, a play on words for when Anne listened to Maurice Ravel's Bolero, this is what she saw in her mind when she listened to the song. There's a lot of very interesting details about this painting. It was considered the best in her career. 6 years after painting it, she was diagnosed with frontal temporal dementia. 6 years after Maurice Ravel composed the Bolero, he was diagnosed with frontal temporal dementia. Let's troubleshoot some common ADL problems. Most of these solutions I've gotten from the Cleveland Alzheimer's Association, Claudia Allen's Understanding the Cognitive Performance Modes, the 36-Hour Day, and personal clinical experience. I've tried all of these. Dining common issues include dysphagia, weight gain and weight loss, which is expected at mid-stage dementia. Do damage control. Let the families know ahead of time that this weight loss is going to occur. Confusion with multiple items at the table. Decrease in table manners. Using a fork to cut their food when they used to use a fork and a knife. Tricks of the trade include offering a simple setup. 1 cup, 1 dish, 1 utensil. Offer food in bowls to simplify. Put syrup on foods to sweeten it up. See clients with a similar dementia level together so that they're with their peers. Routine seating increases PO intake. Small portions. Maybe they'll eat it if they have less in front of them. We just keep putting more in front of them when they're done. Or double those portions if the client does well at a particular meal. Bathing issues. Many clients refuse showers, may become combative with bathing, are not alert enough for bathing, or refuse to get undressed. Tricks of the trade include offering a bath instead of a shower or vice versa. Put blue food coloring in their bath water so that they could see it come up. A rubber ducky is symbolic of bath, and you could say, "Let's go for a walk," while implying where you're going. Leave and come back several times using a repeat approach until the client says yes. Crank up the heat in the bathroom so that it's more comfortable in there. Offer a towel robe so that the client could wear that in the tub as a large washcloth instead of being naked. Play some nice calming music at this time. A lotion bath is also a wonderful hydration therapy for terminal patients to help them clean, but also to increase their skin integrity. Common dressing issues include repeating outfits, wearing multiple layers, sequencing issues such as putting clothing on in the wrong order, undressing or fidgeting with clothing, refusing to get dressed at all. Tricks of the trade include placing articles of clothing in the order of sequence that they would don them, like underwear, shirt, pants, socks, shoes. Work with the client every day to develop a competence. Use a hamper to throw away dirty linens every evening so that the client won't lay them out the night before and believe that they're new the next day. Care plan to dress after breakfast so that the client can do this at their own time. Change the size of the clothing so that it fits better, or put the clothing on backwards if it is stylish backwards. Einstein had 7 of the same suit, so he wouldn't have to think about getting dressed every day. Oftentimes picking an outfit takes too much brain power, so if we have the same outfit every day, they won't get as frustrated. Hygiene and grooming products. Many clients mix up health products because they may all come in the similar types of tubes, jars, or bottles. Make sure you give them a familiar bottle or tube or jar. Some people go overboard on makeup. Men refusing to shave, people forgetting to brush the back of their head, sequencing issues, seeming agitated in the bathroom, doesn't stop brushing their teeth, or urinating in strange places or on the floor. Tricks of the trade include that lineup of items from left to right, like toothbrush, toothpaste, dentures, denture cup, polident. Give a beard a chance. Some men look dashing in a beard. Buy her lighter shades of makeup so that if she applies too much, it's not noticeable. Remove the mirrors from the bathroom if the client feels like there's too many people in the room or they don't recognize who's in the mirror. Put notes next to the mirror to flush the toilet, wash their hands, or to come meet you in the living room. Black toilet seat, elevated black toilet seat, signs such as bathroom, men's room, women's room. Or out of order if they're using the wrong thing to use the bathroom on. If your client has a physical disability, they may need higher levels of physical assistance despite their level of dementia. They will need close supervision, especially if that disability is new. Notice that clients who have a walker before they're diagnosed with dementia are much safer with that walker than clients who are given a walker after they're diagnosed with dementia. Tricks of the trade. There are things that we know as health care clinicians that when clients have an injury and they're getting dressed, they should put their affected side into the garment first and they should take it out last. Clients with dementia have a hard time remembering these types of rules or precautions, so you should also compensate for their misjudgments by buying larger clothing. Signs on walkers can help the clients understand what to do, and hip protectors can help protect the client who is a frequent faller. Get the tight ones with padding over the greater trochanter area. Clients forget rules like transfer towards the strong side, so please practice transferring in both directions in case they do the wrong thing when you're not around. They will at least have the strength. Go up the stairs with the good leg, go down the stairs with the bad leg. The client will also have a hard time remembering this. They might learn through the pain that occurs by not following this rule, but you may need to give them closer supervision with stairs. Sometimes clients forget their mobility devices, so just quietly watch them move around their environment when they do forget the mobility device and see if they are furniture walking, are they grabbing things that are secure. If not, you would want to move those items that are not secure, then give the client back their walker. So compensating and remedy. Give passive range of motion daily with washing to prevent contractures. That is often one of the first skipped cares for long-term care, and it is the definition of insanity that we do the same thing over and over again, expecting a different result. Did you ask your lay caregiver to do daily range of motion for your client, and yet these contractures still come back? The suspicion would be that the client is not doing the range, and I know for a fact that many caregivers don't do appropriate ranging techniques or at all, for it takes too much time to do it. Then why do we keep asking them to do it in the same way? 10 reps of passive range of motion for the upper extremity and lower extremity. This is a protocol that many therapists have used over the years, but it is not necessary to be 10, nor 5, nor 1. You just give your client a long, slow stretch and hold them at full range, and then they will be loose. And if you tell it to the caregivers that they need only do 1, then we're not being insane asking them to do too much, and they're not skipping doing it, and we're not addressing it and still pulling out the contracture. So, hey, it's a long, slow stretch. The client might feel like they're fighting you at part of the range, so you do slow, feels like they're fighting you because that's rigidity. You go a little further, happens again. A little further, happens again, and it's going to happen all the way down. Then externally rotate, they're loose. There's no need for more range if they're loose, because if you keep doing it, they're going to get into a protective fetal position. So just the one time is great. And use sales tactics to encourage the practice of passive range of motion programs. Like, hey, caregiver, how would you like to save some time? How would you like to have less work? Well, with a long, slow muscle stretching technique, you only spend 3 minutes ranging your client as opposed to 15. I'll teach you how to do it. Or maybe you want to use more aggressive sales tactics. Hey, if you don't do long, slow stretch, well, we're going to have to increase the range of motion program to 30 reps 3 times a day. Or bribery also works very well as a sales tactic. Buy people a gift. People love chocolate and gift certificates to Dunkin' Donuts up here, but a good gift would be clear imitation vanilla extract, because that kills the cheese smell in hand contractures. It's bacteria. That's why it won't wash off. We're going to talk a little bit about challenging behaviors, one analysis model, antecedents, 2 behaviors, prevention and predicting behaviors, and making goals. What are some examples of challenging behaviors and interactions in which they occur? What do you think are the causes of those challenging behaviors? Please list some behaviors that you have at your company. Pause this video and maybe list 10. Some behaviors that I've heard reported to me that are challenging are combativeness, exit seeking, stripping, cursing, wandering, rummaging, sexual behavior, refusal of care, excessive emotions, repetitiveness, urinating in the wrong places, uprisings, which was when a big group of people come at you as aggressors, hoarding, delusions, paranoia, and yelling. Let's analyze that behavior. What happened right before the behavior? What happened during the behavior? What was a consequence of the behavior? Through this analysis, we can come up with solutions. What did you do to intervene with the behavior? Did it work? What was the consequence of your intervention? Prevention. What can you do next time to prevent the behavior? Cognition. What stage are they in their dementia? What stage are they in their dementia? This may help give us the intention behind the behavior. So let's say someone's in early stage and they used a pejorative term with the client caregiver. Well, that's a very different circumstance than someone who's in late stage dementia who used that same pejorative term. Here are some potential antecedents to challenging behaviors. The client might have a psychosocial or environmental antecedent. Antecedents are what happened right before the behavior. They could be physically uncomfortable. They could be over or understimulated. They may have recently had a change in routine, environment, or caregiver, which we call sundowning. The task might be too complicated, or they have an inability to communicate effectively, so they do so through behaviors. Causes could also be medical. Weight loss, dehydration, constipation, urinary tract infections. Many medical causes of behaviors are described in the Mitchell 2002 article. They may be fatigued at the time you requested them to do something. They may be fatigued at that activity or event. They may be generally sleep deprived. Do they have a roommate that makes noise all night? Are there call bells going off at a facility? They may be having physical changes to their brain, such as the frontal lobe. It could be a side effect of their medication. They may have impaired vision and hearing and misinterpreted what they saw or heard. Did you say, "Let's take a shower?" And then they asked you to take a shower with them. Sometimes they're very concrete thinkers. Or they're having a hallucination. How do you know if something bad is about to happen? Sometimes they're very nice and they tell you exactly what they're going to do to you. Like, "I'm going to punch you in the nose," or "get out of my way." Sometimes they're very demanding, threatening, or loud. Or they speak with clipped or pressured speech. Clipped or pressured speech. Or they're brooding. Short yes/no answers. Yep. No. Or the female F word. Fine. Increased irrationality. "I'm calling my sister and having her get me out of here. I am through with you." Including those crazy hands, which could also look like this. Oh, no, you didn't. Cursing and using coarse language. "Sister Mary Clarence, I can't believe you used that word." And she might. These are cues indicating discomfort, fidgeting, grimacing, a tense body language, negative vocalizations, yelling, or fight or flight type of behavior. A word on cueing and communication. Behavior is a form of communication, and you should maintain eye contact during conversations. Talk in a calm, clear voice using simple terms. Listen carefully and anticipate what the client is trying to express. Sometimes it's coming out as a word salad. Offer verbal and nonverbal cues to your client and watch your body language that you're not tense. If you're saying, "Trust me," you need to look like you're receptive to their input and that you are trustworthy. Don't look scared. But it also helps to be near the door just in case it doesn't go well. Whatever you do, don't argue, question, correct, try to convince, or take behaviors personally. These are the poison that will exacerbate behaviors. Do acknowledge feelings. You seem like you're upset. You're missing your brother, your mom, you're missing your house. You're worried about your cats. I'm sure they miss you. Encourage reminiscing. What kinds of games did you used to play with your kids? What was your favorite dish that your mom used to make? What kind of house was it? Who did you used to play with when you were a kid? Did you have any jobs as a kid? Reassure. I'll make sure you're all right. We'll take care of you. I'm in charge of you right now, so don't worry about it. Redirect. Let's sit and have some tea. Let's take a walk. Will you help me fold these towels? I'll put on some music. That always makes me feel better. Animals have a calming effect, and so do babies. And if you have any available, that would be great. And if you don't have any available, there are synthetic versions available. And sometimes people think that's a dignity issue, but it's not. It's a sensory tool. It's a tool that elicits a physiological response. It's an IADL. By holding this baby doll, in my lap, it reminds me of when I used to be a mother. And it's actually very comforting to me to hold this because it's reminding me, shh, don't get up right now. Wow, what a tremendous feeling of fulfillment I will have holding this baby, as opposed to wearing a seatbelt, doing nothing, and being told, sit down, sit down, sit down. The best way to manage your behavior is to prevent it from happening to begin with. Increase independence and give control whenever possible. Hey, do you want to wear your green shirt or your blue shirt? Rather than, do you want to get dressed? Hey, this might be the only choice that they get to make all day. Eliminate poor lighting, shadows, glare from mirrors or windows. Reduce excess noise. Don't argue. Acknowledge and validate feelings. Distract with food. Ice cream is a dementia-friendly food. Never ever run out of ice cream. Drink something. Participate in a physical activity. Identify something comforting that may be unique to the client. Some more ways to increase independence and give control include putting labels on drawers and rooms to help the client find their way around. Provide the just right assistance with ADLs, and if being direct seems to offend the client, you could always be indirect. Hey, after you get your shoes on, we're going to go down to therapy and work on your balance, rather than, well, do you want to put your shoes on? Would you like to come to therapy? It might be more effective that way. Indirect observation. Go into the bathroom when the client's in there and wash your hands at the sink and say, I'm here for me, not for you. If being direct, saying, I need to be in the bathroom with you, is not working. Sometimes you don't know what to say. You feel like you're walking on eggshells, and no matter what you say could cause a behavior. Just don't know how to quiet that down. Let's say that Geraldine asks, where is my mother? The truth is that her mother is dead. I could tell a therapeutic fib that she is at the supermarket. Here are some answers to prevent behaviors. Geraldine asks where her mother is. You could tell the truth that she is dead, but perhaps Geraldine doesn't remember that her mother died, and this is a question that she asks every day, and she gets very upset when she has reality orientation. You might want to tell a therapeutic fib. Your mom is at the supermarket, because in Geraldine's reality, her mother is still alive, so we might as well keep her mom busy. I don't like to physiologically harm people by giving them bad news that they don't need to know right now. Like, for example, 2 of our cats died this week. I'm not going to go tell my children on the phone when I haven't seen them for a week while they're with their father. I'll tell them when they ask. I'm not going to give them added emotional distress that they don't need to have right now, which is kind of funny because the last time my kids came over, they were only there for a day, and they were blaming the cat for some of the messes that they were making in the house. And I would love to tell them that I know that they're not telling the truth, but now I'm just kind of waiting them out. All right, we could give a vague answer. She's in a good place. Or half-truth. She's with her buddy, Peter. Or emotional truth. She knows where you are, and she loves you very much. Or validate. I'll take care of you. Or distract. What? She forgot your ice cream. Let's go get some ice cream right now. When you make goals for your client, make sure they're very specific and measurable. For example, the client will demonstrate 75 to 100% post-oral intake for 3 breakfasts. Make sure they're functional. For example, the client will complete their dressing with simple setup and cues for 4 out of 5 days. Integrate your assessments into the goals. Client will complete the Allen Battery within 1 week. A great book to purchase with already pre-written goals and care plans is the Understanding the Cognitive Performance Modes by Allen, Earhart, and Blue, and they're all very cognitive performance-based goals. That'll help because with the Affordable Care Act, your client can become their own outcomes measure, and based on your cognitive testing is a book with pre-written goals based on what the client can, will, or may be able to do. Here are some common physical issues that we address with our clients. Neck flexion contractures, hand synergies, leg adduction contractures. They all also need daily range of motion, and a long, slow stretch seems to help. Physical therapists have better luck getting the clients to do isolated motor movements if they approach those activities in a functional way, rather than just touching the floor and standing on a balance board. It might be better to play 52 pickup, drop a deck of cards on the floor and have the client pick those up. Enhance proprioceptive input. If your client is not walking very well, change their footwear so they could feel the floor better on their feet and they may walk well. Also, remember, proprioceptive input is counterintuitive. The client will lean towards the area of stimulus. So if you're putting up a lateral support in your client's wheelchair, they are very likely to have exacerbated leaning over a few days. It may be better to recline their wheelchair a little bit to resolve that leaning. Work on sitting balance with your clients at the same time that you're working on wheelchair positioning. If they are leaning, we want to work on some trunk stability, do some mat work. We'll talk about what wheelchairs to get in a little bit. Assess your client's cognitive level for walkers, a cane, etc. It may be safer to not have a walker or a cane. It might be safer to have a rollator. It might be safer to have a rolling walker. It depends what the client's familiar with, what they've used before their dementia, what they've used after their dementia, and how they understand the mobility device. I will tell you one thing that makes me different from some therapists is that I'm okay about the rollator. Clients seem to understand how the rollator works intuitively because they have residual motor practice for pushing strollers and shopping carts. Though they move too fast and they don't remember to lock their brakes for the most part, so while a rollator might be the better mobility device of choice, I would not leave the client alone with that walker unless someone else is available. Same thing with a rollator. Which wheelchairs would you get? Think of a versatile style that can be adapted to their debilitating condition because they will get worse over time. Broda is a palliative chair model, and so is Tilt and Space. They are very expensive, though they are less expensive than the lift chair, which oftentimes family members buy for their loved ones, and it takes away all of their trunk tone. I don't like Jerry chairs because your client will lose the ability to walk and transfer within weeks. A dual axle chair is a little less expensive, but it has more versatile options, as does a reclining chair. What are restraints? Restraints are anything that keeps the client from doing what he or she wants to do, and according to the Center for Medicare Services, that includes a lap buddy, a seat belt, a chair alarm, chemicals, your voice, a Mary Walker, etc. And if you are going to recommend a restraint for your client, which if it's following that criteria, then yeah, you might be recommending restraints now. You want to make sure that what you're choosing balances independence, access, safety, positioning, and whatever's least restrictive for your client. I would much rather have my client wear a seatbelt in their wheelchair, if that is considered a restraint, than to have them reclined in a dual-axle wheelchair with footrest, anti-tippers, and auto-lock brakes, and a chair alarm, because that is 5 restraints. So it would be better to just have the seatbelt, because that would be the least restrictive option of balancing your restraints. I'm kind of liking that initiative now, but if you want to be a restraint-free company, that may be near impossible unless you hire more people. Fall prevention. A healthy schedule of leisure activities is the best way to prevent a fall. Give your client lots of activities and many opportunities to walk. Everyone is responsible for putting an activity in front of your client, and don't even say goodbye. You're like Mary Poppins. Give them something to do, and when they're engaged, walk away. Falls are a natural part of aging, according to the Center for Medicare Services, so we just have to make it so it's as safe as possible when they do fall, so they are less likely to get hurt. Although I feel that everybody falls, and just the older you are, the less likely you are to bounce back. But Medicare says what Medicare says. What is sensory deprivation? It is a loss of input to the senses that causes irritability, confusion, depression, and a faster progression of the disease. Sensory stimulation can increase alertness levels, or otherwise called arousal states. And people who are more alert, according to the research, have better PO intake, meaning they eat more. They have less behaviors with their ADLs, and they have less behaviors with their transfers. You could provide noxious stimulation when you don't know what else to do to get them to increase their alertness levels, and that includes clove oil to the tongue, smelling bitter apple, smelling lavender, sternal pressure, light touch, cold, deep joint compressions, bright lights, or high-pitched noises. But noxious stimulation should only be a last resort. Dr. Volliser had taught me to stimulate the 7 senses in order of complexity to gradually increase the client's arousal state, that the client will be less likely to be agitated and are less likely to send them into cardiac arrhythmia. Your simplest sense is your olfactory sense, so have your client smell something for about 30 seconds to 60 seconds. Visual. Have your client look at something for 30 to 60 seconds. Maybe a flashlight, maybe a color, maybe a stuffed animal, maybe a picture. Tactile. Have your client touch something. Proprioception. Give your client range of motion or deep joint compressions. Vestibular. Move the head. Make sure it's only a lateral movement, such as raising and lowering the bed, or sitting up a bed, or leaning side to side. Auditory. Sing a song that your client may know, and sing it twice. The second time around that you sing, your client may start to sing then, even if they haven't been talking for weeks. Gustatory. Taste something or have the nutrition and hydrations. Through this model, you could present themed sensory stimulation, or you could just have it not have a theme. It depends on your client's level of cognizance. If they're in early stages of dementia, you could present maybe a baseball theme. Smell popcorn. Look at pictures of baseball players. Touch a baseball glove. Throw a ball. Do a wave. Sing "Take Me Out to the Ball Game," and then eat some popcorn. Then after that, you would have increased your client's arousal state an entire point on the global deterioration scale, so increasing their cognizance enough to tell them their precautions, work on transfers, work on ADLs, or to have a meal, because the research supports you. And then you could write a goal for that. After 15 minutes of sensory stimulation, client will have improved performance seen in one of those 3 categories.